Today is July 15th, 2016. Kay Wagner is talking with Dr. Richard Fink, a retired orthopedic hand surgeon. Dr. Fink completed his residency at Mayo Graduate School of Medicine. He joined Gunderson Health System in 1973 and retired in 1997, totaling 24 years of practice. Do I have all that correct?
You do.
Welcome, Dr. Fink. We're pleased to have you here.
Thank you.
Jay Chowka is behind the camera. Well, we'll start with where you grew up. You grew up in Illinois, and your father was a doctor and your mother was a nurse.
That's correct, yes. I grew up initially, the first 7 years of my life was in Rogers Park, which is part of Chicago. My father was a general practitioner, as they called him at that time. He had his hospital practice at Swedish Covenant Hospital in Chicago. He had done his internship there, he practiced there, and he died there. So he was very devoted to that hospital. When I was 9 years old, we moved to Skokie, Illinois, which was just a small community at that time, and some of the family had already moved out there. And certainly when it came to choosing medicine as a field to go into, my mother and father had a big influence on me. Another thing that really influenced me was the fact that I was born with club feet. And in growing up, I had a lot of treatment. A good part of my first few years I spent in casts, and I was in corrective shoes for many years, and then ultimately at age 9 I had a major operative procedure on one of my feet, and I was treated by Dr. Harold Sofield, who was a prominent orthopedic surgeon in the Chicago area. He eventually became president of the American Academy of Orthopedic Surgery. So I had a fair amount of orthopedic experience by the time I was 10 years old, actually. And then, like any kid growing up, I was pretty rough and tumble, and I had a couple of fractures here and there. And so the smell of plaster is something that has stuck with me since childhood.
Were they able to completely correct it for you?
Well, as much as you can do. Certainly I'm very fortunate in that I've gone my whole life and I've been able to practice orthopedics and participate in a lot of sports activities. There are certain ones that I couldn't participate in because of my feet. And these days I do have some arthritic problems with my feet that limit me some, but all in all it's been a good result. And I must say my parents were very supportive to me. I was a firstborn child, and of course they had high hopes, I suppose, as anyone does for their first child, and they were very supportive. They never showered me with sympathy, and yet they never put any limitations on me either. They took good care of me, made sure I had good medical care, but otherwise ignored it and gave me my full leash to do as I was able to do. And I've always been grateful to them. Many years later, as an orthopedic resident, I met a fellow named Rudy Clausen who was at Mayo, and he had talked about being in Tunisia. He worked with what we call an NGO these days, and he told me that had this happened in Tunisia, I probably would have been taken out in the desert and left because they just don't have good ways to treat such things in a lot of parts of the world. So I feel very blessed to have been born where I was and have had the parents I had who never let this get in my way. And I've rarely talked about it.
Yes, I guess I don't know exactly what to say. I mean, it's touching, and especially since you had such a supportive family. Did you have siblings as well?
I did. I have a brother and a sister.
And you were the firstborn?
Yes, my sister is 3 years younger than I, and my brother is 7 years younger.
And what do they do?
Well, they're both retired now. My sister was a teacher, and in the Denver area, and my brother was a talk radio show host in Appleton, Wisconsin.
Interesting.
Yes, we have some interesting conversations.
And he's retired as well.
He is.
How about your education and training?
Yeah, I went through the public school system in Chicago and Skokie, and then for college I went to North Central College, a small school in Naperville, Illinois. I had graduated from a very large high school. We had, I think, 1,200 students in my graduating class. And then I went to North Central, where they had a total of 800 students. And that was a good experience for me to go to a smaller college. And I have nothing but good things to say about small schools and what they can do for a person. From North Central, I went down to Tulane University down in Chicago. Down in New Orleans. And I went there. It seems odd that I would leave the Chicago area to go down to Tulane, but there again, my father really influenced me on that decision. Tulane had a very good reputation, and he had experience working with a couple of doctors. Doctors Baffis, they were brothers who worked at Swedish Covenant Hospital, and they had trained at Tulane, and he had been quite impressed by the amount of knowledge that they had accumulated. And so I was there from 1964 to 1968, and I must say I really felt I had a very good education there, and a unique education, because I think we saw things down there that there are very few places in this country that you could see. Just because of the socioeconomic status of many of the people down there. The location in the South provided us with a significant South American and Central American population that would consult up at Tulane. We had a lot of things like parasites that were commonplace down there that you rarely see in the North. And then from Tulane, I was looking for an internship, and I wanted to come back up north. I really wanted to live in the upper Midwest. And so I went to Duluth, Minnesota. My mother had been born on the Iron Range up in Virginia, Minnesota, and so I knew Duluth to some extent. And my family's had a cabin up on the Gunflint Trail out of Grand Marais since I was 4 years old, and so we go through Duluth a number of times a year going up there. And they had a very good internship, and so I went up there. And then from Duluth, I went down to the Mayo Graduate School of Medicine for my orthopedic residency. And spent 4 years there. The last 9 months, I was what's called a chief resident associate at Mayo. I basically had my own practice. 3 months of that I was in the Rochester State Hospital doing general orthopedics, and then I was really fortunate to spend 6 months doing hand surgery at Mayo. And that was a difficult time because I had my own practice, but I also took call virtually every day. For 6 months, and it was a lot of work, but I feel so honored to have had that experience. So it was a very fortunate situation. And then from there, I came directly here. Now this was Vietnam time, and like most everybody who was in medical school at that time, I participated in the Berry Plan, which was a lottery system. In the Berry Plan, some people had to go into the military, depending on the draw, right after their internship. Some got to do a year of residency and then go in, and some were deferred for the entire residency. And you also tried to decide what branch you wanted to go into, and so on and so forth. And I just really was fortunate. The draw came up. I got the Navy, which is is what I wanted. And then I got deferred for my full residency. And then a few people, instead of having to go in after their residency, it just depended on their manpower needs at the time. And so when the time came that I was getting close to finishing my residency, I contacted the military, and they said, and this was at the time Vietnam was winding down, and they said, well, you probably won't have to go. And so I started looking for a job, and I came over here. This is the only job I really looked at seriously. We can talk about that if you want, but I was offered a position, came over here, interviewed, did the whole thing, and offered a position, and I accepted it, and then I got a letter.
Oh.
And it says, you're going to have to go in, report to Great Lakes, and blah, blah, blah. And so that sort of threw a monkey wrench in the gears. And, well, we had about 6 weeks, I guess, during which time we sort of rationalized, well, that'll be okay because we'll be closer to the family and that sort of thing. And then all of a sudden I got another letter saying, well, we've changed our mind. You're not going to have to go after all. And so I wrote right back to Gunderson and said, I'm here. And I was able to go to work here. I did have to be in the reserves, I think, close to 10 years. And I came out when I finally got my honorable discharge, I came out as a lieutenant commander, never having worn a uniform or saluted anybody or gone to a meeting or anything. And so it was kind of a strange series of events, but so was Vietnam, I guess.
Going back to the attraction to Gunderson and being the one place that you seriously looked at, what attracted you to Gunderson Health System?
Well, when I was looking for an internship, we had a book, I can't remember what it was called, but it was a list of all the internships in the country. And I had looked at Gunderson and their statistics regarding, how much of the time their internship filled up, which was an indication on the quality of the program. If a program consistently filled up, you kind of took a second look at it and thought, well, something must be attracting all these people there. And I had looked at it, but I was pretty intent on going to Duluth, and so I didn't do anything about it at that time. But then in my residency, during my last year of my residency, in the first year group was a guy named Randy Gall. And Randy, who eventually became one of my colleagues here, had done his internship, well, at least a year of residency here before he then went to Vietnam. Randy and I are the same age. Rocky Marciando, another one of our orthopedic colleagues, he's also the same age. And but both Rocky and Randy had military commitments, which, as I explained, I did not have in the same way, at least. And so Randy started the program at Mayo at a younger age than I. But Randy kept telling me about Gunderson Clinic and how he wanted to come back here and how much he thought of the program. So that I started listening to Randy and what he was saying. And then a good friend of mine over at Mayo, I had a neurosurgery rotation there and had met a fellow named Charles Rodman, Dr. Charles Rodman, who became a neurosurgeon here. And Charlie and I became good friends. And I knew Charlie had come over here. And so I gave Charlie a call. And how's it going and that kind of thing. And he had great things to say about it. And I asked him, if they were looking for an orthopedist. And, oh, yes, they certainly are. And so I went ahead then and made contact with the appropriate people here and eventually came over and met the three orthopedists who were here, Dr. Hayden, Dr. Tompkins, and Dr. Haug, and interviewed here. And I really liked what I saw. I liked the kind of a practice that it was because I, of course, had spent 4 years at Mayo in a similar group practice kind of a setting. And again, my father influenced me. And he kept telling me, that's the only way to do it. He said, individual practice is going to die. And by golly, it took a while, but he was right about that and so many other things. And so anyhow, I ultimately made the decision to come here with a little bump in the road here and there with the military commitment.
Did the aspects of medical education and research that were integrated into Gunderson, was that also an appealing factor to you?
Yeah, that certainly was. I did not have a great interest in research, but just the whole nature of the practice appealed to me very much. The idea of having all the support around you and not having to send people across town to another office to see an internist or a general surgeon or something like that. I mean, everything was right here in one compact place. And the other thing I liked about it, quite frankly, was the financial arrangement. We were salaried. We were not paid based on how many patients we saw in a day or something like that. And I like the idea of being able to make a good, objective decision, and knowing my colleagues would as well, about how to treat a patient, and not have to look at, what it was going to, how I was going to be reimbursed if I did it this way or that way. And the other thing I liked about it was, all the office management stuff was done by people who were trained in office management, administration sorts of skills, and I could practice medicine and not have to worry about all that. So basically, I knew that I could provide good care to patients, and I could feed my family, and I'd not have to worry about all the administrators wouldn't want me to call fluff, but what I considered fluff, I guess.
Yes. How many clinicians were here when you joined the clinic? Do you remember your number?
Yeah, mine, I don't remember my specific number. It might have been 93, 94, somewhere in there. It was between 90 and 95 was my number. Yeah.
And how many clinicians were practicing at the time? Do you remember?
I just always assumed it was about 93 or 94, but I may be in error about that.
Yeah, I don't have the figure on that either. Well, you also were involved in non-clinical activities. You were a member and chairman of the Medical Legal Affairs Committee.
That's correct.
For 19 years.
Yes.
And also the Self-Insurance Committee and Governance, and chair of the Professional Services Review. What are some of your memories of those commitments, challenges?
Well, the real plum, in my opinion, was the Medical Legal Affairs Committee, as we called it. And the reason I really liked that is because I learned a tremendous amount about law doing that. I had an opportunity to, when I first started doing it, to go to a seminar up in Eau Claire that was actually aimed at malpractice attorneys. And that was quite an interesting experience. I learned a lot about what the law says about allegations of malpractice, how attorneys prosecute them, how they defend them, when they decide to make settlements, when they fight them to the very end, and just sort of the mentality of an attorney. And I realized that the mentality of an attorney is far different from the mentality of a physician. And so that was a real eye-opener for me. And virtually every situation in which a physician felt that there might conceivably be the possibility of litigation, they would run those by us. They'd fill out a formal report on that. And so we'd go through all this, and I just learned a lot about litigation, about when relationships between physicians and patients break down. Even if the patients had had great care, sometimes they don't get the results that they anticipated, and so it was a really good educational experience. Plus, I got to meet a lot of attorneys that I never would have met otherwise. And as an orthopedist, we do a lot of, we see a lot of people involved in accidents, one sort or another, falling downstairs, automobile accidents, industrial accidents, whatever. And so there is a lot of legal implications to these things, insurance companies paying out, or workers' comp paying out, and so forth. So as orthopedists, we do a fair amount of testimony. And being on this committee just gave me a whole different insight as to what was going on, and I think really helped me.
And you were able to bring it back and share it institutionally as well.
Yes, yeah. One of the things we did when I was on that committee is we went through our entire history of malpractice litigation. And of course, when I started doing this was just at the time when the big swoop upward in litigation was occurring, not just in orthopedics, or not just in medicine, but in a lot of other areas too. And so we were able to catch the coattails of that and be right on top of it based on our previous experience, which we'd evaluated. And it was just a kind of an exciting time to be involved in all that.
And what about the professional services review and governance? Any memories?
Yeah, that was a committee that was chaired by Dr. Kiskin, Dr. William Kiskin, who was a general surgeon here. And it was basically a time when we wanted to review the whole concept of governance in the clinic, and what physician governors, if you want to use that term, what they should actually be doing, and obviously they're working hard at, and how they should be compensated for it, and so on and so forth. And so that was an interesting committee. There was one that I forgot to give you on the list that I was on that I was reminded of yesterday, and that is I was on the original Energy Conservation Committee, I guess. Yeah, that was chaired by Dr. Sig Gunnarsson. That was, it was probably about 1980 or so. And Gene, we heard this talk yesterday at the Emeritus Staff Breakfast about all the energy conservation things that are being done here, and generating stuff from cow manure, or electricity from cow manure, and all that kind of business. And our big decision when I was on Dr. Gunnarsson's committee was whether or not we should be turning the lights off at night. So we were pretty primitive, but that was the start.
And an early one, too.
Yeah.
When we talked a little bit about medical education and research, so let's move on to your specialty, and how has that evolved over the term of your practice, or currently? What was the biggest innovation that you've seen in the field?
Well, I think three things in the time that I've been involved in orthopedics. One is total joint replacement. And when I was over in Rochester, I started there in 1969, but I had actually spent the summer of 1967 there as a medical student in the orthopedic department. And, they were just getting geared up to start doing joint replacements at that time, and it was total hips at that point. That was the only joint. And people were going over to visit with Dr. John Charnley in England, who developed this technique. And by the time I started there as a resident in 1969, they had actually started doing total joints. I think in the previous March, they did their first one. So that was a major thing. And then, of course, this thing blossomed out. They developed joint replacements for knees, elbows, shoulders, just about every joint you can imagine. Something's been tried, some of them very successful. And so that's been a big thing. And I will note that one of the things that attracted me to coming to Gunderson was as I explored what was going on here, I found out that, gosh, they were doing total hips here. And here's this group of 3 orthopedic surgeons who were right on top of things, and they too had gone over and spent time with John Charnley, learning how to do this technique. And boy, for a group of 3 orthopedists doing that early, that was pretty remarkable. It was usually just the really big institutions, university-based institutions that were doing those things. The other major, well, there are 2 other major things. One was the development of internal fixation for fractures. At the time I finished my residency, every effort was made to treat fractures conservatively, which means non-operatively, because there was always a risk of infection and always a risk of non-union whenever you opened a fracture up and tried to put a plate or screws or something into it. Some you had to do, and there was some limited internal fixation. But then there was a group primarily out of Switzerland, involved Germans and some other Europeans too, but the group was based in Switzerland that really went a long way to developing internal fixation. And originally in this country, it was picked up by the veterinarians because they've got a different patient clientele from us that's not nearly as cooperative and hard to keep in casts or whatever. And actually, the first talk I ever heard on internal fixation was, I was probably a 2nd or 3rd year resident in Rochester, and it was a veterinarian that came down from the University of Minnesota who lectured to us on internal fixation. And well, that eventually took off, and hospitalization went, for example, for a femoral fracture, people were routinely hospitalized 6 or 8 weeks in traction. I mean, nowadays they put an intermedullary rod down the center of the bone, and they're out in a couple of days, sort of a thing. And of course, that has great implications for cost of care. The results are much better, but the reason is the equipment has been developed to a point that it's so much better than what was available when it was first being started. The third thing is endoscopy. The first endoscopy talk I heard was by a fellow from Toronto who was one of the real pioneers in looking inside knees with an endoscope, what we now call an arthroscope. He came to Mayo when I was probably in my 3rd year and gave this lecture and showed these pictures, that he'd taken through the arthroscope. And the orthopedists on the staff, I remember some of the comments, and well, this is an interesting research tool, but it'll never have any clinical applications. And well, that developed too. And I came over here, and I was here 3 or 4 years, and it was really starting to look pretty good. And so Dr. Tompkins and I went over to Michigan and learned how to do it from a guy named Lanny Johnson, who was one of the pioneers in this country. And Lanny Johnson was actually taking out torn menisci, torn cartilages in the knee using the arthroscope. And the original equipment we had was really primitive. We had this big cameras. You held it up over the patient. It was all sterilely wrapped, of course. And the thing was about this high and about this square. It was heavy. And then we had an arm that came from that was articulated. And, there are 3 or 4 joints in this so that ultimately it would hook on to the arthroscope that we were using. And you could look in the knee. You'd have a television monitor. You'd look in the knee. But every time you moved it, these joints would move. And so the picture was constantly going like this. And you'd almost get motion sickness doing this. And, well, the equipment fortunately improved considerably. And now, there's little tiny television cameras mounted right on the arthroscope. And Boy, let me tell you, it's no research tool now. It's, they do all kinds of miraculous things, not only in the knee, but so many other areas as well. Of course, it's spread into general surgery. They do all kinds of belly procedures with it and so on and so forth. So those are the three things that really, really changed in orthopedics. A lot of orthopedists had the same experience I did. By the time I finished practice, I was hardly doing any operations that I learned as a resident. I mean, things had changed so. And so it was a fun time being orthopedics. There was, a lot of progress, a lot of new stuff to learn, and there's a lot of stimulation to keep going to courses and meetings and so forth.
Sounds like it. Now, in terms of the hand surgery, what about the nerve regeneration and transfer? Was that part of some of the innovation that?
Yeah, that there was a lot of progress in that area too. That was more, not development of technical tools like hip replacements and arthroscopy and internal fixation. It was more learning about what the capabilities of nerve tissue and other tissues was. And by the time I left my residency, there digital nerves in the fingers, there are only maybe a millimeter and a half in diameter. They were routinely being repaired. Replantations were being done, where vessels were, a digit could be cut off and reattached by, they'd figured out how to repair the vessels and have the blood flow, work as it should, and how to keep it working. And so there were a lot of improvements that way too. There were improvements in the microscopes that we were using to do this work and so on.
Sounds like it was a wonderful time, as you said.
Yeah, it was.
Lots of energy and.
Yeah, it was an exciting time being orthopedics and in hand surgery, which is where I ended up subspecializing.
How many cases would you handle in a month
of
hand surgery?
Oh, well, by the time I left, my elective practice was almost entirely hand surgery. And, oh golly, I don't know. My operating days, I think I operated 2 days a week, and we'd often be doing 6, 7, 8 cases a day. And a lot of them were fairly quick cases, carpal tunnel releases, for example. I mean, those are, you have to know your way around it, but after you've been doing it for a while, you can get in and out pretty quickly.
Was that one of the top?
Yeah, carpal tunnel, I think, was probably the most common procedure that we did. But then, I mean, we do very complex, lengthy procedures too, rheumatoid arthritis, hand reconstructions, which would involve joint replacements, tendon transfers, that kind of thing. That was probably at the other extreme. Those procedures could go several hours.
Was Gunderson sort of at the top of the, in terms of practice, probably right at the top in terms of knowledge and skill?
Yes, I think we were. Mm-hmm. Yeah, we. I was fortunate to have quite a bit of extra training in hand surgery at Mayo before I left, and then my colleagues were just really good about making sure that I had plenty of hand cases to do. They, when I think they became confident in my skills, they often referred things that they might ordinarily try and do themselves to me. And then later on, I was joined by Chip Hayden, Dr. John Hayden's son, and so between the two of us, we did quite a large volume, and I think in the community in the area, our skills as hand surgeons became known, and had a lot of referrals as a result.
Did you do any outreach efforts? I mean, did you travel to?
We did some. I, in fact, did some surgery over at St. Francis. There was a time there when St. Francis did not have the hand surgery skills that we had, and yet, we'd see patients that, clearly their preferences were to go to St. Francis, and so we tried to provide, the option of having their surgery done there, and I didn't do huge volumes there, but I did several cases a month for a while at St. Francis.
Anything else about the particular field that you want to share, your specialty?
Oh, I don't know. I could tell you how I got into hand surgery.
Do.
As I say, my father was a big influence in my orthopedic experience. My personal orthopedic experience was a big influence in going into orthopedics. But when I was in 7th and 8th grade wood shop, I had a teacher, Mr. Kirchhoff, and he was a gruff old guy, and a lot of the kids were really afraid of him. But I found out I had some skills in wood shop, and he recognized that, and he and I became good friends, and I just really enjoyed wood shop, and I knew that someday I wanted to be doing something where I could be using my hands, and as a mechanic, sort of a thing. And I think I had a lot of genetic mechanical background. I, in fact, came from a family of locksmiths. They'd come over from Germany to Cincinnati in 1835 as locksmiths, and all the kids afterwards, it seemed, went into locksmithing or making safes. And my grandfather and my great-grandfather installed big vaults. I mean, really big ones. You see these big round doors. They were doing all that kind of work. And then my dad, when he graduated from high school, he worked for my grandfather for 4 years before he went back to school. And so I think genetically, and I continue to see this in my grandchildren, they have great mechanical skills. And so that contributed to my interest in orthopedics. But then I became very interested in sailing. And this is crazy. I tell some of my hand surgery friends a story, and they think that I'm nuts. But in many ways, you can compare the stays that hold a sailboat mast up, and if you ever look at one closely, it's pretty complex. You can compare it to the hand, and when you think about tendons and ligaments and so forth holding things together, I mean, just imagine. Look at all the things that you have in a hand. You've got this bone, this one, this one, this one, a bunch of little ones here, and the forearm. And if you were to take pieces of wood and try and hold them up like this, using various strings that are like tendons and little check reins that are like ligaments, it'd be a pretty complicated affair. And in many ways, it's like a sailboat mast. And so I guess my interest in sailing and the technical aspects of sailing spilled over, and I really got interested in hand surgery. So,
You probably were able to even do repairs on the boat, if needed.
oh yeah,
And they usually are.
and they were needed, and yes.
Well, you are a loyal donor to the foundation. What motivates your ongoing support?
Well, I think they do really good work here, and I'm just really pleased that they have the quality of a residency program that they have to train people that are going to follow those that are here now. And I came from a residency program that was a good program and trained orthopedists to go out all over the country, and orthopedics in this country is really good now. As a result of their efforts and other institutions. And I see the same thing here. And so that's part of it. But part of it is I have family in town here. And donating to the foundation, I think, helps ensure that not only is Are my wife and I going to have good care, but my children and my grandchildren, and maybe their children eventually too, will have good care. I think it's good for the community. Good medical care attracts people to the community, and it just kind of builds on itself. And as people get attracted here and start businesses or work for businesses, they contribute to the foundation, hopefully, and they just keep this thing going. So I feel very strongly that it's a very worthwhile charity in my list of charitable organizations.
Do you have a favorite story about Gunderson? Patient who changed you? Miraculous day?
Oh, I have a lot of stories. I'm kind of a storyteller, and you may have figured that out. There were some interesting experiences that I had. One of the things that happens here is we have Fort McCoy over here, and they do a lot of things over there, but one of the things they do is they have big parachute jumps every so often. They bring a couple of planes load of paratroopers from Fort Bragg down in North Carolina, and they jump them over Fort McCoy. And I've learned from this experience that they can almost predict precisely how many people, it's kind of a risky activity, and they can predict how many people are going to get hurt, what kind of injuries they're going to have, depending on whether it's night or day or winter or summer. And this one winter I was on call, and we got word they were going to be jumping about 600 of them. And so I knew that it was going to be a busy evening. And so they had their jump, and sure enough, about 11 o'clock at night, this was a night jump they did. Ground was hard, it was frozen. And about 11 o'clock at night, I got the first call. We got 3 paratroopers in here. And so I came down the emergency ward, we got x-rays, and we ended up having 11 paratroopers that night. There were 2 types of fractures they had involving the leg. One actually was of the ankle, and the other was of the lower part of the leg. And if you put up those x-rays and you put up all the ones of the ankles, they all looked exactly the same. And if you put up the ones of the legs, they all looked exactly the same. And the treatment that we carried out is we put them in big bulky dressings called Robert Jones dressings with plaster splint in it to keep them immobilized, and yet if they swelled up a lot, this bulky dressing would allow them to swell and not cut off their circulation. And we put them all up on 3 center, the orthopedic floor, and boy, those guys were tough. There was not an aspirin taken among them that entire night. Nobody wanted to admit that they were having enough discomfort that they needed to take something. And so we had a regular assembly line assembling these, or putting these dressings together in the emergency ward, and then the next morning we made arrangements. They all got packed off back to Fort Bragg to have their treatment.
They didn't require surgery?
Well, they ultimately did, some of them, depending on the injury. And a couple of years later, I ran into an old friend of mine from the residency program, and we got talking, and he says, "Yeah, I was in the military. I was down Fort Bragg." And I said, "Do you recall a situation where a bunch of, told him this story?" He says, "By golly, I thought those Robert Jones dressings looked, familiar." So there was that one. There's another story that I love to tell. It involved 2 motorcyclists, and they had been drinking a bit. And they were out here on the interstate and going across the I-90 bridge across the Mississippi, and this was early in the spring. Water was still cold, and they had a little too much drink, at least one of them did, and he managed to go out of control and hit the side of the bridge, and he went flying over the bridge into the water, and in the process broke his arm. And his buddy, seeing this and realizing that his friend was in trouble, dove off the bridge. and and pulled them out of the water. And there happened to be a couple of guys down there walleye fishing, and so they helped get these guys into the boat. Well, they brought him in here, and the one guy really had been drinking a lot, and of course he was uncomfortable. And oh man, I tell you, the language was, the room was blue with his language, and he was swinging at everybody. And well, his fracture was open, and in other words, he'd broken the skin, and so we had to take him up to the operating room to clean that up and try and prevent infection. So I took him up to the operating room and got him fixed up. And the next morning, he'd sobered up a bit, and he was just the nicest guy, nothing but apologetic and very grateful for, the care he was getting and so forth. And his buddy was there, and his buddy says, I never would have jumped after him if I hadn't been drunk. Well, the fella healed up just fine, and, I continued to follow him in the clinic. And then 2 or 3 years later, I was out at the mall with my 2 sons, and they were, 10, 12, 14, something like that. And we're walking through the mall, and all of a sudden this group of about a half a dozen people in leathers and, tattoos all over and chains, and they come walking along there, and they see me, and they come up and, "Oh, Doc, how are you?" And they're putting their hands, around my shoulder and stuff. And my kids are standing there with their mouths wide open, and they left, and they said, "Dad, you know those guys?" So anyhow, there were a lot of good stories like that. There were sad ones too. One time, I've always felt, one of your questions was if I ever had a bad day. I always tried to really be honest with my patients and tell them the truth as best I knew it about things. And one day I got a call from Dr. Ledbetter, who was a resident in general surgery at the time, and she had a patient in the emergency ward that had been in a motorcycle accident. He had a couple of fractures. I don't remember exactly what they were, but so she called me, and I drove down. This was late at night, and I had a look at him, and indeed he did have, I can't remember what it was broken even. But from the time she called me, the time I got down here, things are really going downhill. Blood pressure is dropping, high pulse rate. And on going over him, at that point, things had changed a bit from when she first assessed him. And it seemed pretty clear that he had major bleeding in his belly. And he was crashing fast. And so we quickly called Dr. Fred Sheldock, who was the general surgeon on call. And this guy was going down the tube so badly, and he needed his belly opened. And we actually, Dr. Ledbetter and I took him up to the operating room to get him up there and get him ready. And Dr. Sheldock came out, and he was already asleep on the table. I mean, we had done something that under normal circumstances I never would have considered doing, but this guy was in deep trouble. On the way up there, I went with him on the elevator, and he looked up at me and he says, "Doc, am I going to make it?" And I said, "Yeah, you're going to be fine." And Dr. Sheldock came in there, and he wasn't very happy, as he had a right not to be, because he really hadn't had a chance to evaluate the patient. We're asking him to open the guy's belly. Well, he did. And the liver on this fellow was just, it looked like somebody played football with it. It was just torn and bleeding, and he died on the table. And that has haunted me. I told him he's going to be okay. So there are a few sad stories like that too.
Does that outweigh all of the good things sometimes?
Oh no. I mean there were. Well, it troubles me obviously. When I think about it, I try not to think about it, but I do. But there are so many cases that really difficult fractures that you learn basics of fracture care in orthopedics in a residency program, but nobody can tell you about everything. And so there's a lot of creativity that one has to use. There was a great reward in having a really difficult fracture and putting it together and having it go well. And so, there were many, many good experiences, but there were a few difficult ones. People talk about going to war, seeing terrible injuries, and PTSD, so on and so forth, seeing their buddies horribly wounded. But what I think a lot of people don't realize, orthopedists see that as a part of their routine work. I mean, we saw some horrific things. Men whose legs were cut off by railroad trains. I remember two guys that came in from Fort McCoy that somehow got involved with a landmine. It shouldn't have happened. Not in training, but had their lower limbs just torn asunder. And they're coming in and we're being asked to do something about that. I mean, where do you start? And so there's an awful lot of that, quite honestly. And, I've talked to other orthopedists about this sort of thing, and it's an amazingly tough group of people. It's amazing that they don't have more difficulty. I dream from time to time, even now. This 19 years since I retired, and I still have a dream once in a while that I wake up in a sweat over. But that's the nature of the specialty. And I make it sound kind of grim, but really, I loved orthopedics. The reason was that almost always we were making people better. I mean, they might come in with horrific things, but if they made it in the door, I'm talking about trauma patients now, if they made it in the door of the emergency ward, they were probably going to survive. The fellow that I told you about with the liver injury was an exception. Most of them make it, at least the patients that we as orthopedists see. And from there on, you're making their life better. You may not make it perfect, but they're going to be a heck of a lot better than when they came in the door. And this is opposed to specialties where they're dealing a lot with cancer, for example, where, some people they do make better. A lot of people, they're simply trying to make things as good as they can be until they die. In an orthopedics, it's really a happy specialty. And as I say, I don't mean to let these ugly parts of it imply that orthopedists, I think, are some of the happiest people that I know of. They really enjoy what they do, and I enjoyed very much what I did.
Regarding the man that he just bled out?
Yes.
Yeah.
Yeah.
Because of the
Just
damage.
couldn't keep up with it. He was bleeding so heavily.
Any other patient stories?
Well, let's see. let me just refer to my notes for a minute. You did ask, and I hesitate to even talk about this, but you did ask if there were any patients that influenced me. And there was one. It had a profound influence on me. It was a woman that was involved in a motorcycle accident along with her husband. She was a passenger. And I think they were hit by a car, as I recall. And she had several fractures, but one of them was a femoral fracture. She was a little tiny gal, and at that time we were treating femoral fractures with traction and then ultimately a cast. And the treatment wasn't nearly what it is now, but we didn't have what we have now available. Such things now would be treated usually with an intermedullary rod. Take them to the operating room, put a rod down the center of the bone, and you have all sorts of ways to get everything lined up just right and so forth. But, I did the best we could with what we had available at the time. She was in traction probably 6 weeks and then in a cast for several weeks afterwards. Everything healed up well except her femur, which failed to heal. And so after a period of time went by and we gave it every opportunity, we recommended that she have it operated on and bone grafted. And so I did that. And at that point, we did put an intermedullary rod in to hold things in place. And the equipment wasn't nearly as good then as it is now, but it did the job. And then we took some bone graft out of her ilium, which is the wing of the pelvic bone, which is a common source of the graft. We put that graft around to try and stimulate healing. And it took a while, but it ultimately healed, and I was very glad for that. And she seemed to be happy with it as it was. The only problem was she had some shortening, which was not at all uncommon then. Again, it's because of the equipment that we had available. A lot of times you can avoid that now with the various things that can be done with internal fixation, but we couldn't really control it then. And ultimately, this went on for 2 or 3 years that I took care of her. We actually, I thought, became pretty good friends. And I finally saw her for the last time, and I said, I think that we're at the point where we can call it quits, and if you have problems, let me know. But otherwise, I think we've done everything we can. And she did have some shortening of the leg as a result of all this. She was going to use a shoe lift to accommodate that. A week later, I got a letter from her attorney and informing me that I was being sued. And it was a terrible feeling. I really felt like I'd been betrayed. I never, ever saw this coming. And it profoundly affected me. It's when somebody does something to you that you're just absolutely not expecting. It affected my relationship with my patients. I suddenly started looking at people with a certain level of suspicion. Is this going to happen again, sort of a thing. It profoundly affected my family. I wasn't the same person for a couple of years when this thing went on. And I just wasn't my usual bubbly self, so to speak. I constantly had this thing weighing on my head, knowing I had done everything that I could do, and knowing that other people who reviewed the case said the same. And ultimately, at the end of 2 years, we'd been scheduled to go to trial, I think, 3 times. Each time the the young woman's attorney canceled it at the last minute. At the end of 2 years, they finally decided to drop the case, that they didn't have a case. But it took 2 years out of my life and 2 years out of my family's life, and it really did affect the way I looked at my practice. It wasn't quite as much fun anymore. And quite honestly, it was a major factor in my making a decision to retire early. Unfortunately, that's an experience that many orthopedists have had. Orthopedics is one of the most at-risk specialties for litigation. I mean, we're dealing with all these horrific things, and we have all these good ways to deal with them. But it's hard to take something that's just been smashed to pieces and have it be normal. It's just the human body it's not like a car where when the carburetor quits working, you put in a new carburetor and everything's going to run fine. The human body is just not that way. And there are a lot of reasons these things happen. Some people may not have insurance, and they've got these bills. Maybe that's going to change now with the new healthcare laws. They're out of work for periods of time, and there are a lot of factors that go into this, and I think sometimes it's not that they're really after the physician. They're just so desperate to cover their personal finances, and I can understand that. But it's a shame when people get asked to be responsible for something when they've done their very best, and they've literally done the best that can be done. Well, as chairman of the Medical Legal Affairs Committee, I saw a lot of this, and I saw several people on the staff that were really quite devastated by litigation that they didn't see coming, that they honestly didn't believe that they deserved. So
I'm sure you've thought about this endlessly, but do you wonder, or do you think that you understand the motivation behind this? There was not a long period of time before she filed.
Yeah. I don't know in this specific case. I suspect maybe she'd been seeing the attorney somewhere along the line. Maybe a friend suggested that, you sue your doctor and maybe you get a few bucks there to cover your time out of work or something. I don't know. I don't want to even speculate. Yeah. But I've thought many times, maybe what they ought to do is have insurance programs that people can take out when they are going to have a procedure done, for example, so that if things don't go well and if they've got some coverage. I mean, we have insurance for our cars, that if you get in an accident, your car gets repaired. You may have to pay a deductible, but the car can get repaired if it's not normal. I don't know. That's for society to figure out.
Well, let's move on to a happier topic.
Yeah, let's do that.
Do you have any advice or words of wisdom to offer young physicians entering medicine?
Well, it's a challenging time, and we don't know where it's going. Physicians are generally pretty smart people, and it's possible to get an education in something else and potentially do a lot better than financially, for example, than you can as a physician. Maybe have more free time. Although if you're going to work hard at anything, you have to put time into it. So we have a lunch group that gets together down at Diggers on Thursdays, and the question comes up at times. Somebody will say, my neighbor's got a daughter who's really smart, and she is thinking about going to medical school, and my neighbor asked me what I would recommend. What would you guys recommend? Well, we all kind of scratch our heads at this point. I think if somebody, it sounds corny, but if you really want to help people and do some good things for people, there probably isn't any better field to go into than medicine. So, this is a personal decision, but nobody should do it based on the idea, certainly not on the basis of, they're going to make a good living, but not necessarily. You can make a better living doing other things. But if you want to help people, and if you have that in your heart, it's a good area to go into. Now, with specific reference to orthopedics, as I say, orthopedics is generally a very happy specialty, in spite of some of the things I've talked about. It's generally, orthopedists are just happy people. So it's a good area to go into. But you're going to go into orthopedics, you have to accept the fact that you're going to be up early in the morning, you're going to be staying at the place late at night, you're often going to be called out in the middle of the night, and I mean often. At an institution like this, if you're on call, it would be a rare night that you didn't get called out. And there's no point in going into it if you're not going to be dedicated to it. You're going to have to just accept the fact that your life is going to be somewhat disrupted. You can't be sure that you're going to be at your son's concert. Something may come up that may well take you out. I think it's important, if you're going to go into orthopedics, that you pick the right woman or a spouse or whatever. That person has to be very understanding, and they can't be jealous of their time with you. When you're on call, you sort of just plan your life that you're going to be called. But there are days, too, when you're not on call. And, you get a call on the phone that the guy on call is up in the operating room. He's got 3 cases backed up. I've got a hand case down here that needs to be taken care of. I can remember one Easter dinner where I spent it in the emergency ward taking care of a guy with a snake bite of his hand, because the orthopedist who was on call was busy, up in the operating room. So that kind of thing happens. So you got to pick the right spouse. If you have children, you got to hope that they'll understand. I had a very good relationship with my father. He was very, very busy. Yet when we kids had time with him, we really treasured that time. And so I sort of knew what was coming there, what my sons would have to endure. But they pay a price too. You're not always able to be at their concert. You're not always, able to be at various functions they would like you to be in. It's hard to be a Boy Scout leader if you're going to be an orthopedist. That takes a toll.
Do you think that your family adjusted to it well? You married the right woman, and
I did marry the right woman. And I think my sons look at life a little differently now as a result of their experience. I think they've chosen, they take advantage of every bit of their spare time to spend with their children.
Are they physicians as well?
No. Neither son became a physician. And I think seeing our lifestyle, that of my wife and me, I think that made them decide early on, excuse me, that they were not going to go into that area.
What area did they go into?
Well, I have one who's a semi-truck driver for Ace Hardware, the Ace Distribution Warehouse. And so he's all over the Midwest driving, and spends generally one night a week out in his truck, which he has to do as part of his job. But he spends a lot of time with his kids. And I have another son who works for a hedge fund down in Chicago, and he has nothing to do with trading or anything like that, but he's kind of in charge. Well, he is in charge of basically their computer infrastructure, picking buildings that are safe from a risk standpoint. You don't get a building at the end of an airport runway, for example, for some things at least. I mean, he's basically what they call a network architect. They design the computer rooms, and they make sure there's redundant power coming in and so on. But the point is, he travels all over the world doing this. I mean, he flies back and forth to Europe and Asia like like we go out to dinner. Yeah. He's gone many times a year to Europe or Asia. But when he's home, he spends every bit of time that he can with his children.
So they're both married and have
They
grandchildren?
are, yeah. They both marry lacrosse girls.
I want to go back to Gunderson for a minute here. What would your colleagues say that you'd be known for?
Well, I hope that they would consider me as having been dedicated, that I would respond to the call when I got it, that I was hardworking. I hope that they would consider me to be to have the ability to do the work. I think one of the highest compliments one can have is when a physician asks you to take care of their family. And I felt very fortunate to have several physicians, specifically ask me to take care of family members. And that's a great honor. I mean, literally an honor. So I'd like them to think of me that way.
And what would you personally, are those the same things that you would personally like to be known for?
Well, yes, those I think are, if I have a reputation, those are great things. I'd also like to be, Adolf Gunderson used to talk about three things that a physician should have. One is ability. He talked about the 3 A's: ability, affability, people liking you as a physician, and availability. And he thought if you had those 3 things, that would make you successful. I'd like to think I was affable too. I tried to be. I think of Adolf, and then I think of, I can't remember, it was Will or Charlie Mayo, what he used to say the requirements for a physician should be. And one is to be older and have hemorrhoids. And he thought you should be older, so you had gray hair and you looked distinguished and knowledgeable and so forth. And then hemorrhoids for that look of concern. So there are all kinds of things. I liked Adolf's, actually.
Well, the interview wouldn't be complete without talking about the travel that you've done and the things that you're enjoyed then and enjoying now in retirement.
Well, I retired early. Early on, when it became apparent that there's going to be a lot of night work and so forth. My wife and I had a long discussion, and we decided that I'd go ahead and work hard and get the job done, and not be moving around shopping for practice where I didn't have to work hard or as hard and so forth. And we decided that I would aim to retire at 55. And so we lived, I think, relatively frugally. We saved our money, and we didn't do as much traveling, perhaps, as we would like to have done. And yet we went ahead with this goal. And when I became 55, I had to make a decision about if I was going to actually retire or not. Now, I have always had a passion, and I was blessed to have a wife who had the same passion for the sport of sailing. And we raced small boats throughout our life together. And we decided that someday we'd like to own a larger boat and travel with it, try and make up a little bit for this time as working. The other thing we wanted to do is we wanted to do some volunteer work overseas and do a little traveling on that basis. And so ultimately, when I did become 55, for a variety of reasons, mostly positive ones that we wanted to move on and do these other things, I did retire at 55. And we bought ourselves a nice boat big enough for two people, a good seaworthy boat that we could literally go anywhere in the world with. And we set out to do that. And we spent several years on the Great Lakes. It was kind of hard to break away right away because we still had family obligations and parents who were alive and needed some looking after and so on. But we got to sail literally over all of the shores of the Great Lakes, and some several times, and really enjoyed doing that. And in the meantime, we were able to take some trips with other people. We did one trip from Durban, South Africa to Madagascar with a friend on a somewhat larger boat. There were 6 of us on board, and we spent 5 weeks cruising up the west coast of Madagascar, seeing parts of Madagascar that are very difficult to see because of the road conditions and stuff there. We were able to see and visit them by water. I have a lot of stories about that trip, and I could go on for a day talking about them. It was quite an experience. I also did another trip through the southern Caribbean. We went through the Panama Canal and cruised the Sandblast Islands off Panama, which are the classical South Sea islands. Went to Colombia and Aruba and Curacao. Very difficult trip. I went, my wife did not go. I was chosen because I have a great resistance to seasick. I've never been seasick. And it's a very, very heavy weather trip. And we were again on the same boat that we did the Madagascar trip with. And this man, he unfortunately died a couple of years ago. But he was probably one of the most experienced small boat sailors in the world. Small boat, his boat was 56 feet. It was a sizable boat, but still small when it comes to oceans. Mm-hmm. He actually was the first person to go through the Northwest Passage over the top of Canada, first American to do it from east to west. He did that at the age of 76. I was invited actually on 3 attempts that he made, but because my wife by that time had become ill, I was not able to go. I would love to have done that, but it didn't work out. I've had tall ship experience. I was a volunteer deckhand on the Dennis Sullivan, which is a three-masted schooner out of Milwaukee. We took it from Milwaukee out the lakes, down the St. Lawrence River, out past the Canadian Maritimes, and then down the Atlantic to Nassau. It was a 2-month trip. And that was a very different experience for me. I'd not had any tall ship experience prior to that. Climbing the mast, doing all that kind of business. And I've got a professional license. The sea is really in my blood every bit as much as orthopedics, I guess. And I've been very fortunate to do these trips. And that's sort of hereditary too. I had a Norwegian grandfather who spent a lot of time at sea, and he was a big influence on that part of me. And then my wife and I did some overseas volunteer work in Fiji, and then we went to Madagascar as well. And those were good experiences, for which we were very grateful.
And I guess I'm kind of at the end of my questions. Is there anything else that you'd like to add?
Well,
more about your family, or?
Well, I tell you, I feel very blessed in life. I've just had a wonderful life, and for which I'm very grateful. My wife, my first wife, to whom I was married 47 years, and we did a lot of interesting things together. We went through a lot of, bumps in the road together with the old family and so on and so forth. Through my training and so on and so forth. So I was blessed to have her. She unfortunately developed scleroderma, which is a very serious illness, and that kind of curtailed our sailing plans, and she became actually quite ill with it and was very ill for about 5 years. And then she passed away back in 2012. And but I've been very fortunate to have remarried since then, and to a woman that I have known practically since the time I came here. She used to work as a scrub tech in orthopedics, and Joanne Shepke. And after Donna died, Joanne and I started seeing each other and realized that we had a lot more in common than just the operating room. And so I've been twice blessed to have two wonderful women in my life, for which I'm very grateful. And so Joanne and I are now, planning the rest of our life together and hoping to do some more adventures and so on and so forth. And so that's kind of the end of my story, I guess.
Well, it's certainly been a pleasure to visit with you and hear your story. And when you talk about orthopedics being a happy specialty, you beam when you talk about it. It's so visible to me that it's something that made you very happy.
I should mention that part of the pleasure of being an orthopedics here was the three colleagues that were here when I first came, and the ones that followed. John Hayden was the first orthopedist here, and shortly thereafter he was joined by his friend Doug Tompkins, who John had met in his residency. And then somewhat later they were joined by Steve Haug, who came out of the University of Iowa program. There were three fine colleagues and three people that really attracted me to this place and made me stay here. John and Doug had trained with a couple of people who were on the staff over at Mayo, and when those folks heard that I was interested in coming here, they had nothing but the highest regard of John and Doug, and told me all about that, how highly they thought of them, and so and they've been very fine people. John Hayden is now, I think he's 93, and still a polite gentleman that he always was. Doug Tompkins unfortunately passed away earlier this year, and Steve Haug unfortunately died at all too young an age of cancer. But they were just wonderful people to work with. Rocky Marchando and gee, I'm having a senile moment here. Randy Gall, excuse me. As I say, they're the same age as I, and they were just wonderful colleagues. So the six of us ended up practicing together for a number of years, and then the department really started growing, and we've had a number of very fine people join the department. And while I don't know the new ones nearly as well as the ones that were there in my time, the things that I hear about them are nothing but good, and so I'm very proud of the department and what I, as one of the original people, helped to develop.
Unfortunately, we went over to Dr. Tompkins one day, but he wasn't feeling well enough, so we missed him, and Dr. Hayden isn't able to interview either. So thank you for bringing this up, because it gives me an opportunity to maybe ask you what they would like to be known for, what they were essentially and critically to this institution, since we won't be able to visit with them about that.
Well, I can't speak for what they would like to be known for, but I tell you what they are known for. The three of them were really known for hard work. I mean, those three people were covering the orthopedics of a community that's now covered by, I don't know how many are in the department now, but it's a dozen or more, I think. And they really worked. John Hayden was, such a gentleman, and so good with people and so caring, particularly children. He had quite a significant amount of training in children's orthopedics, and so he was originally the go-to person for children's problems. Doug Tompkins was very academic. He really knew the literature. He did some writing himself, made some very important contributions, particularly regarding the elbow in the literature. And Steve Haug, Steve was just a wonderful man. And just Steve Haug kept me going at times when I was just so beaten, dragging, that because Steve could make you laugh. Like, Steve would tell these stories, and half of the laughter was from the story, and half of it was watching Steve tell it. He was just such a jolly, happy man, and a good orthopedist. And I'll never forget a trip that I took with Doug Tompkins. He and I were going over to Mayo to watch one of the orthopedists there do a shoulder replacement. And that's when we were first thinking about getting into shoulder replacements. Again, very early in the game of shoulder replacements. And Doug said to me, he says, "Rich," he had a way of talking. He said, "Rich, you're the second best thing that ever happened to us. Steve Howe was the best thing." And that had to do with the amount of work that they had, that he and John Hayden were doing. And then Steve, they added Steve, and that was just a big relief to them to have that third person. So I was the second best. But he had a good sense of humor.
Well, that's good to hear. Good to.
That was a great department.
Mm-hmm.
And they really, they wanted to be on top of things. And, you know, when a new technique came on, well, I'll tell you about the first day I was here.
Okay.
You know, that's orientation day. You know, you come to the clinic and you spend the day walking around with somebody, learning where medical records is, learning where the operating rooms are, learning where radiology is, where to get your x-rays, where to get your lab reports. You spend the whole day doing this. It's an important day. Well, I came the first day, and on that particular day, again, learning a new technique, Doug Tompkins and Steve Haug had gone out to California to learn how to do a knee replacement. It was a Dr. Marmer out there, and he had developed the Marmer knee, and it was the thing to know about at that time, probably the best knee at the time. And so Haug and Tompkins are out there learning about the Marmer knee. So I come in for orientation. John Hayden is on call, and I'm here about an hour, and John Hayden, for the first time in the whole period he's been working here, he had to go home sick. He was ill, and there was no way he was going to be able to make it through the day. And so I am getting my orientation, and suddenly I'm on call. Well, being on call is a busy thing here. I think about 5 minutes into my call, I got a call that there was somebody in the emergency ward with a fractured hip. And then it just kept piling up. And I spent that whole day either in the emergency ward or in the operating room. And I never did get oriented. I still don't know where all these places are. I eventually figured it out, but I got oriented in a different way.
Right off the track.
Yeah.
Yeah. Well, we sure appreciate you coming in today. It's been, as I said, wonderful to visit with you and see you again.
Well, thank you. I've enjoyed the opportunity, and I've told you a few things I haven't told many people.
Thank you for that.